I'm Tom Jeerakathil. I'm a neurologist and a professor of neurology and medicine at the University of Alberta. I'm also the Northern Stroke Lead for our Cardiovascular and Stroke Strategic Clinical Network. Stroke is a major public health problem that involves damage to the brain. And in terms of worldwide, out of the 60 million deaths or so that occur every year, 1 in 10 is from stroke. And it's a major cause of disability in adults. So imagine a disease that actually produces damage to the brain, and every minute that goes by, that damage increases. So out of 5 people that have a stroke, 1 person dies from it, another person is left in a nursing home, another person will get home, but they need a lot of help just to get through their basic activities of life. Another person will get home and can function reasonably, but may not get back to work. And then 1 in 5 people with stroke make a reasonable recovery whereby they can get back to doing what they were before. The nice thing about stroke from blocked arteries is there is a treatment for it. If you open up the artery quickly, you can actually restore blood flow. And you can have a person who would be doomed to either death or severe disability actually make a good recovery and possibly, in a best case situation, walk out of the hospital within a few days of treatment. Now that's the best case scenario. This is surprisingly difficult to do. So you need to do about 20 things between the time the patient arrives at the hospital and the time you can give a clot-busting drug. And if you move the clock back even further backwards, other things have to happen before the patient even gets to the hospital. Someone's got to call 911, the ambulance has to arrive. All these things actually have to happen before you can give a clot-busting drug safely to a patient. So in Edmonton, we've been working on this now for a number of years. Calgary and Edmonton have both had their local quality improvement campaigns to drop their door-to-needle time, which is our measure of good and fast stroke treatment. So Edmonton's made a lot of progress in the last few years, as has Calgary. So we've actually joined forces and also joined forces with rural hospitals that are also giving clot-busting drugs in this project called the QuiCR project. QuiCR is a cross-provincial project which is really focused on stroke research, but particularly on quality improvement for stroke. And the thing we're tackling right now is fast door-to-needle times. What's happened in the last year is if we think about the situation province-wide, 10 years ago, we were treating patients across the province in about 70 minutes. Our door-to-needle times were 70 to 75 minutes. About a year ago, the cross-provincial door-to-needle time was 68 minutes. Since the launch of the QuiCR project in September of 2016, that time provincially has dropped to a median or an average time of 37 minutes. And we've dropped as low as 30 minutes. Now the worldwide standard currently is 60 minutes. So if you treat people less than 60 minutes, we feel overall that you're doing a reasonably good job. In Alberta, and actually in Canada now, we don't feel that that's fast enough. We think it's difficult to treat people faster. But if we can save another 60 million brain cells, treating them within 30 minutes compared to 60 minutes, we think that's worthwhile. And so that's what the QuiCR project is all about. And really, it has produced this change that has previously evaded us. So what we've done is we've actually embraced quality improvement techniques used in business. What QuiCR is trying to do is we want to make sure that all the different tasks that have to happen are happening at the same time. So in parallel rather than in series. And unless you're watching it and paying attention to it, you'll never realize that this is actually what's happening, and you won't realize that this tendency to do things one at a time is actually slowing down your treatment. So we had a coordinator monitor all of our door-to-needle time episodes, and she found that things were being done one after the other. So we changed that around to do different things all at the same time, which often means getting more health professionals in doing multiple things at the same time to actually make things go along faster. You can do other simple things. For example, if the patient arrives on an emergency medical services or an ambulance stretcher, which they all do, you don't need to move the patient off the stretcher to take them to the trauma bay or to the CT scanner. We call it stretcher to CT. Take them right from the front door to the CT scanner on the emergency department stretcher. The other thing you can do is we'll scan the patient's head, and once we've determined that it's the right kind of stroke, we'll give the clot-busting drug with the patient right on the CT scanner. So that saves us about 5 minutes transferring them from the CT scanner back to the trauma bay. So that's an example of treating as quickly as possible. And really, door-to-needle time is about keeping necessary delay. You always need to be safe, and you need to understand your patient, and removing unnecessary delay. You want to remove those pauses in care that don't really contribute to care, while keeping all the good stuff. And so we think we can do all of this in less than 30 minutes for most patients, but not for everybody. There'll be patients that need a breathing tube. They'll be extremely complicated. They won't be treated in 30 minutes. So there'll always be patients that are treated in a longer period of time. We'd like to get our average treatment time to be less than 30 minutes. Well, I think we've made a lot of progress in QuiCR, but the work is never done. There is a saying along the lines of better has no limit. And so first off, I hope that we can actually attain our sub 30-minute average target. We're so close, we're minutes away. So I really hope that we can do that. I hope we can expand our quality improvement efforts to other areas like transient ischemic attack. I hope that we can take this QuiCR model and use it to make advances and to make change in other areas of stroke care. And I hope this kind of a lesson can actually be disseminated across the country. Because if we take this kind of approach and use it for stroke across the country, or maybe even for other disease states, we can actually produce a lot of improvement. And my hope is this actually translates into tangible improvement for patients with stroke that actually suffer this devastating disease.